Abhilash Dhruv. So my talk is on treatment algorithm for post-discectomy discitis. So disc-space inoculation during surgery is the most common cause of a discitis following a discectomy. Incidence is variously reported to up to 4%. Modern papers will say it's less than 1% because of improved antisepsis. Diagnosis requires a very high index of suspicion because if untreated, undiagnosed, or people who are failing treatment, this simple discitis can progress to spondylodiscitis. Treatment is not yet standardized. So a patient comes to you, what's the first thing that you do? You order for your labs. So your CBC, the WBC is not always reliable, it need not always be raised. What is important here is ESR, which is a slow rise post-op and a slow return to baseline in 4 weeks, and a CRP which has a rapid rise with a peak on second post-op day and a rapid return to baseline in 2 weeks time. The ESR and CRP used in conjunction in a patient presenting with typical severe back pain following surgery, usually third or fourth week after surgery, should increase CRP and ESR should arouse the suspicion of infection. Again, doing a baseline also helps you in monitoring response to treatment. People get blood cultures done, but literature reports blood cultures are usually negative unless there is the presence of an epidural abscess on an MRI in which it's almost 60% positive. X-rays, now X-rays basically help us in finding out any overt instability or any bony destruction. They are of questionable purpose for finding these things in an acute phase. The changes on X-rays are usually seen only after 4 to 6 weeks. Dynamic X-rays are out of question in acute phase because of the back pain, but they are of some use when the patient goes into a subacute or a chronic phase. CT scan is similar to X-ray, but of course it is better in demonstrating the bony defects, and also it helps us in planning implant placement. A contrast enhanced MRI is the investigation of choice. Part of the discussion was done in the earlier session. Signal changes in discitis are typical hyperintensity on T2, hypointensity on T1, and on contrast enhancement you will see the entire disc-space lighting up. Now, MRI is of use also to diagnose, to find out the presence of any epidural abscess, nerve compression, paraspinal abscesses and collections. Next, the biopsy. Now, biopsy is very controversial here because there are variable percentages of success ranging from as low as 40% to as high as 96%. One thing is certain, a thin bore needle biopsy is something which has very low yield. If you have to do a biopsy, do it with a thick bore needle. Whether you do that a CT guided or a C-arm guided by the surgeon himself is up to you. Whenever you get a biopsy done, always send it for smear culture antibiotic sensitivity for aerobic, anaerobic, fungal as well as tuberculosis. And do not forget to send it also for histopathology. Bone scan, just a passing mention, not commonly used for infections, but only in cases where there is still some suspicion whether there are end-plate changes or is it actually infection. Bone scan is of some value. So treatment, the general principles of treatment are first thing, obviously the patient has come to you with severe pain, so pain relief in the form of rest and analgesics, and you have to eliminate the infection. So antibiotics are the mainstay, whether you club that with surgery or not, we'll see. Preservation of neurology, of course, when the patient comes back with a deficit in discitis, surgical debridement is the choice. You may couple that with instrumentation and spinal stability. Whenever compromised, you have to instrumentate. So quickly, you have diagnosed discitis on the basis of all the investigations that we just discussed. Now you find out whether there is a neural compression, instability, epidural abscess. If it is not there, you go for conservative management. What exactly do we do in a conservative management? So, conservative management is always the initial therapy given in patients who have no deficits or patients with significant comorbidities which preclude any surgical intervention, and patients who have no instability. So, it includes prolonged bed rest, sometimes even up to 6 weeks for pain relief. IV antibiotics are the mainstay. I believe we have a lecture coming up on IV antibiotics. We'll just touch upon that. Typically 6 weeks of IV antibiotics followed by 6 weeks of oral antibiotics. Whether they are sensitive antibiotics based on biopsy or empirical depends on how you approach the patient. You have to monitor response clinically by seeing improvement in pain and laboratory investigations where we say we are seeing declining CRP and ESR. Now, whether to mobilize or not with or without orthosis is again very controversial in literature, but it is still an issue where you have to keep the patient in bed for 6 weeks. It's always better to mobilize it as the pain allows with an orthosis. So now you've done the conservative management, but the patient is showing no improvement, or you have all the neural compression, instability, abscess and deformity. Those are the patients where you have to suggest operative treatment. Now, if there is any sort of instability or deformity, if there is none of that, you can go simply for debridement. Whenever you debride, it is mandatory to send the material for biopsy. The debridement can be open or minimally invasive. You may put a bone graft and always follow that up with the conservative management protocol with regards to IV antibiotics. In case there is stability or deformity, it's a no-brainer. You have to operate in the form of debridement plus fusion. What type of fusion? It can be either a posterolateral fusion or could be an interbody fusion. Again, you always have to include that with the mainstay of treatment being the antibiotics. Always follow that up with the conservative. So as mentioned, surgery, we do that in failure of conservative management or presence of overt instabilities. What surgery does is it reduces the bacterial load. We address neuro deficits by surgery. Now coming to the question of whether to instrument it or not. Remember, the endpoint of treatment or endpoint of the natural history with after giving antibiotics is fusion, whether you allow it by conservative management or actual fusion. So debridement of disc space is an accepted therapy. You will still require the patient to be in bed. We are not addressing the immobilization issues in this. Whenever we have to go in for radical debridement, removing excess bone may cause instability. So uninstrumented fusion also has reports of some amount of pseudarthrosis, subsidence and deformity. So instrumented fusion is an accepted method. It's absolutely safe. It in fact has superior outcomes when it comes to fusion. You can also address the deformity in that. Immediate mobilization is present based on the stability of your construct, and you are not going to skimp on removal of bone with the fear of causing an iatrogenic instability. So instrumented fusion, there is minimal risk of a biofilm formation on implant when it is inserted after the radical debridement is done. Besides stability, aids in healing. Whether to do the interbody fusion or not, radical disc space debridement will anyway cause interbody fusion. Now interbody fusion, whether with an autograft or allograft or cage, all of them show good results. Posterolateral fusion, where you are just putting the screws, grafting on the sides and just debriding the disc space, is also accepted. PLIF basically is not a great option when you have to do nerve decompression as well, because you are going through a lot of scar tissue there. Now, TLIF remains an excellent option. So to summarize, the entire algorithm, as we just discussed, the initial treatment is conservative management. Whenever there is compression, instability, always go for operative treatment. Thank you.